right, good afternoon, everyone. Welcome. This is another in a series of the Melanoma Research Alliance's patient meetups. My name is Dana Dayton, Director of Communications and Engagement for the Melanoma Research Alliance, and I am excited to be moderating this webinar. We'd like to thank all of you for joining today. This month, as you well know, is Melanoma Awareness Month, and the topic of this webinar is From Skin Checks to Clinic Visits, Understanding Melanoma Prevention. And it's another in a series of webinars designed to engage, educate, and most importantly, empower patients and caregivers. MRA is sponsoring this webinar in honor of Melanoma Awareness Month. Before we get started, I have a few housekeeping items to go over. By joining this webinar, you understand that this will be a public event and recorded as a resource for others that will live on the MRA website. Portions may also be shared via MRA social media channels. The content should not be used as a substitute for professional medical advice, diagnosis, or treatment. Please consult with your healthcare provider about any questions you may have regarding a medical condition. Please keep your line muted and other devices silenced. Also, please be respectful of the experiences, opinions, and questions of others. And now, with that behind us, it is my pleasure to welcome two of my favorite people in the melanoma space. Dr. Arbesman is a physician scientist who specializes in melanoma treatment and research, a dermatologist who treats individuals at high risk of developing melanoma. He studies skin cancer risk factors with the goal of helping his patients through all aspects of their care. Dr. Arbesman is a leading expert in the field of genetic risk factors for melanoma. He has challenged the idea that melanoma is one of the least heritable cancer types by demonstrating that up to 15% of cases are associated with inherited pathogenic gene variants, and has shown that many of these variants influence a tumor's response to immunotherapy. By studying genetic risk factors for melanoma, Dr. Arbesman hopes his team will be able to identify new areas of skin cancer prevention beyond reducing sun exposure, expanding the options available for at-risk individuals. And we also have Leah Adams, our patient advocate and MRA Leadership Council member. Leah Adams is the program director for the National Kidney Foundation serving Ohio's office. She has been with the organization for almost 7.5 years. In her role there, Leah manages the planning and implementation of all NKF programs in the Northern Ohio Territory to support kidney patients, caregivers, and raise awareness in her community and educate healthcare professionals. Personally, Leah is an avid runner who has run one ultra marathon, four full marathons, and she loves to hike in her local Ohio parks and state parks. And she loves to travel whenever the opportunity presents itself. When she is off the clock, you can find her advocating about skin cancer, sun safety, and sharing her stage 1A diagnosis and her father's stage 4 metastatic melanoma story to anyone who is willing to listen and learn. So clearly, Leah has quite the steeped background in advocacy, and we're so happy to have both of you. And before we move on, I wanted to pay a special thanks to Renee Orsioni, our Associate Director of Comms and Engagement here at the Melanoma Research Alliance, who has planned this webinar and made it possible for all of us to join. So with that, let's get started. Dr. Arbesman, I am so happy to have you here. I've really enjoyed hearing your talks at some of MRA's events. And I would love to have you help us kind of set the stage by telling us what melanoma is and how prevalent it is across various demographics.
Yeah, firstly, thank you for having me. It's really awesome to be here and talk about melanoma, which is near and dear to my heart. So in terms of melanoma, I'll go very basic and then build on that. So melanoma is a type of cancer, starts from what are called melanocytes or pigment producing cells in our skin, but also in other places of the body that could be in the eye, it could be in the mouth. But the major type of melanoma that we see is predominantly on the skin, and we'll talk probably more about that later on. And melanoma can occur at any age. It's quite rare in children in the pediatric population, sort of peaking it in our 60s in terms of when sort of the average age of getting melanoma is. About 1 in 50, about 2% of the population will get a melanoma over their lifetime. So it's definitely not the most common cancer, and it's not the rarest type of cancer that can occur. Um, and we see it's more predominant in people of European ancestry, but it can occur in all different types of skin, and across all sorts of body sites. So just because an area has never had sun in your life, you can still get melanoma there. And one other important fact that I would like to add, is that we often think of melanoma starting in a pre-existing mole and sort of a mole that changed. And that is definitely true, but that's probably only about 30% of melanomas on the skin will start from pre-existing mole. Actually, about 70% of melanomas will start what we call de novo, or sort of just newly on the skin, a new spot that you notice that continues to change and evolve and grow. And so that's actually the majority of melanomas. But there is a certain percentage, as I mentioned, that will start from a pre-existing mole. And so that's good for us to know what are our, lifelong moles? What do they look like? And are they changing, or are they sort of stable over our lifetime?
Great, thank you. That is a great setup. And of course, melanoma is nothing that anybody wants, but over 8,000 people, will die of melanoma this year, and over 100,000 will be diagnosed with an invasive melanoma. So we need to do all we can to learn about prevention and early detection. And Leah, you've kind of had to, learn, by like being thrown into the frying pan. First with your dad as a caregiver, and then unexpectedly yourself as a patient. And you had to quickly learn the ropes, quickly understand, what it means to, take more precautions, and also establish a relationship with a care provider that you could trust, and that, you can work together with as a team. So can you kind of walk us down some of that journey that you've been on?
Yeah, absolutely. Well, first and foremost, thanks to the MRA for having me. It's a really surreal moment getting to do a program like this with my very own dermatologist, Dr. Arbesman, who has taken great care of me over the years. But yeah, melanoma touched our lives, I say our family's lives, because this is not only my story, but it's also my dad's story. And he was actually the first one diagnosed back in 2019, a month prior to my diagnosis. And he was, I believe, just a newly 6-year-old at the time. So Dr. Arbesman's timeline around 60s kind of tracks for my dad's story. And, kind of some context of, our story. We were not a family that prioritized sunscreen. We've had both a lot of sunburns in our lives, and just didn't really protect our largest organ, which is our skin. And there was a suspicious mole on my dad's back that my mom actually pointed out late in the summer of 2019, and encouraged him to go get it checked out by a dermatologist. And that mole was biopsied, and it came back stage 0 melanoma, what is also called in situ. So that was taken care of as an outpatient procedure, was told he needed to go back for skin checks every 6 months. And we thought that, we put melanoma in the history books then. But then around a month later, my mom spotted a mole on my chest. And she encouraged me to go to the dermatologist. I clearly was not 60 years old at the time. I was actually a fresh 20. I was actually right on the cusp of turning 26 years old. And so my thinking was, oh, 20-year-olds don't get melanoma. Like, it makes sense why my dad got it, because he just, turned 60. And so I kind of brushed it off with my mom and didn't think that I needed to go. And then I think just one day happened, about a week or two later, I just decided, you know what, let's just go to a skin check. Let's get it taken care of. And I'm sure it's nothing. because I heard from friends my age getting precancerous, lesions or moles taken off of them. So I just assumed if it was something, it would be something like that. So I went to my first skin check ever at 26 years old. I had no idea what to expect. And lo and behold, after checking me head to toe, the mole on my chest, the one that my mom pointed out, was the one that they wanted to biopsy that looked concerning to them. And so a couple weeks later, I got the results back, and unfortunately, it was stage 1A, bordering stage 1B melanoma. And the very first thing that I thought about was, this is worse than what my dad's was a month prior. I knew how stage 0 melanoma was treated. I had no idea how stage 1A, mind you, bordering stages into 1B, how that would be treated. And Dr. Arbesman was not my dermatologist at the time. It was another dermatologist. And when she called and told me my results, she let me know that melanoma is the fastest spreading and deadliest type of skin cancer. And it just was so surreal to hear that, because I didn't, again, think that 20-year-olds could get melanoma. And so she let me know that she wanted to get me into surgery to get the melanoma removed off of my chest. And then, as a precaution, also wanted to move forward and get a sentinel lymph node biopsy, which is it's a procedure where they will remove a couple of lymph nodes to see if the melanoma spread to my lymphatic system and or local organs. And that was a really hard phone call to hear at that age, just turned 26. And it's really kind of when my life really turned around. And I went into surgery, and, it was just a really eye-opening experience, because at the time I've only ever had my wisdom teeth taken out. That was the only surgery I've ever had. And I guess I wasn't really prepared for what stage 1 melanoma was and how it was going to be taken care of and what my life was going to look like after that. After melanoma, I had to make a series of lifestyle changes, had to start wearing sunscreen, which I never really wore before, being mindful while I was outside. And I will always say that, I was one of the fortunate ones that it was caught early and it was treated early. And my sentinel lymph node biopsy showed that the cancer did not spread to my lymph nodes or local organs, which I was super grateful for. But it just really kind of opened my eyes to everything. And so COVID happened, and that was a strange time. And I think, for me, I wanted to really find other people my age that also had melanoma, because at the time I only really knew my dad. And so I started reaching out to melanoma organizations such as MRA and some other organizations. And I was just wanting to find community and find connection. And I also opened up about my social media, or about my story on social media, and was also able to connect with incredible individuals on social media as well. And then, I was feeling a little bit more secure kind of in my journey a year out. And then my dad's melanoma unfortunately came back in January of 2021. And we found out because he had a seizure while driving. And luckily, he was with my mom at the time. And they rushed him to the hospital, and they did a bunch of tests. And they saw that there were lesions all over his brain that caused the seizure. And then they also did a full body scan and saw that there were lesions all over his lungs. And even just looking at the scans, doctors were saying that the lesions were resembling what metastatic melanoma looks like, which when we heard that news, that was a lot to process, because we thought we left melanoma back in 2019 for both my dad and I. And so when a lung biopsy confirmed that it was stage 4 in his brain and lungs, it was really awful, to hear that news. Mind you, again, it was in the height of COVID. I wasn't even allowed to see my dad in the hospital. My mom was kind of the primary person, and it was really scary. And so I think really that experience and seeing my dad go through 21 rounds of immunotherapy, 7 rounds of gamma knife radiation to his brain. It really just opened my eyes to what melanoma can do. And my dad and I have a really interesting story that not a ton of people can relate to, that we had the same type of cancer, but it really presented itself so differently compared to stage 0, stage 1, and then stage 4. And so, kind of in summary, as you all that are listening can imagine, this has completely changed my life. It's led me to be a really strong advocate for melanoma and skin cancer and sun safety, because there's a stigma around melanoma that it's just skin cancer. And to me, it can't be just skin cancer when I've seen people pass away from it. And so, yeah, that's my story, and that's why I'm here today.
Well, thank you so much for sharing that. It's really an incredible story, and we're so grateful that you are so open to sharing it because it will teach others and help educate them, to how they can, prevent pretty much the same experience from impacting their family. So with that, because you and your dad clearly are related, and you said it was the same type of melanoma, Dr. Arbesman, you have experience in heritable cancers. So, can you please talk to us a little bit about that, as well as how different demographics might experience melanoma? What do people need to know from different backgrounds?
Yeah, thank you. And obviously thank you, Leah, for sharing your story. And it's my pleasure to be your dermatologist. So I think I'm allowed to say that, at least in this kind of setting, not in a professional setting. I'll stop making jokes now. In terms of heritability, I think this is a really important topic. So thank you for letting me talk about this. We we've known for a long time that there is a genetic component to melanoma, but I think we thought it was a much smaller component of risk for a lot of people within the melanoma sphere. And I think as the data are shifting, we're realizing that it's actually a larger portion of that. So I'm going to start off with sort of a baseline sort of recommendation, then move more into a little bit more detail. So we've said for a long time that if someone has had a melanoma, their first degree relatives, their parents, their siblings, their children should get skin checks, because they're at an increased risk for melanoma. So we've known that for a long time, and we just sort of say that as a blanket statement. Then sort of building on that, we know the people that are most at risk for melanoma are people with light hair, light eyes, difficulty tanning slash increased rate of burning. And all of these things are actually genetically sort of imprinted on us. And so I think when we think about those things, and one other thing, having an above average number of moles is also something that markedly increases your risk for melanoma. And all of these are genetically encoded, not really driven by sun exposure. So I think those things, even rough senses, indicate for us some of those genetic components there. And then layered on top of that is we're starting to understand, are there particular genes with significant alterations that are relevant for melanoma risk? So for a long time, we knew there was a gene called CDKN2A, which dramatically increased your risk for melanoma, maybe 20-fold, if you carried a significant change in that gene. But having a change in that gene was incredibly rare, even in patients with melanoma. But as we're discovering more and looking more at more genes, both that have been known to be associated with cancer and those that have not been, sort of new genes that are being explored, we're realizing that we can build on top of that. And we find that more and more genes are relevant for melanoma risk, maybe not increasing your risk 20-fold, but maybe increasing your risk 2-fold or 5-fold. And those are still important because that means that those people that carry that genetic change should be screened for melanoma. And the way I would put it, where it's a little bit more contextualized it as well, is that I mentioned at the beginning, your lifetime risk to get melanoma is about 2%. And so even if you carry one of these genetic risk factors, CDKN2A would be sort of all the way at the extreme, we know that CDKN2A is the most extreme. And in that situation, maybe 80% of people that carry a genetic change in that gene maybe will get a melanoma by the age of 80. Those are the rough numbers in the United States. that's predominantly in people of European ancestry. It has not been well studied in non-European ancestry individuals. But say, for example, you increase your risk fourfold with, say, some genetic change. That goes from a 2% lifetime risk maybe to 8 to 10% lifetime risk, depending on a variety of other factors. So that's not a guarantee, but it just means we should be more mindful of it in certain families. And we definitely know that melanoma runs in families. And so I think that's also important. I also think that means that we're learning more and more about what those genetics are, and that's some of our research that we want to add to that, so that we have more of the knowledge, so that we can be proactive in the appropriate people. The other aspect that's critical there is that some of these genetic changes increase your risk for other cancers, and so knowing that as well then is powerful um, to get screened for those cancers as well. Um, so, for example, we find within some of our patients that they may have BRCA1 and 2 gene alterations, which we know are BRCA genes. Those increase your risk for breast cancer, ovarian cancer. So, if you find that you have one of those genetic changes because of a melanoma diagnosis, that can be something that we can be more proactive about for other cancers, to reduce our risk of breast cancer or ovarian cancer, or screen more appropriately. So, I think what I would also say to the demographic question, two things. One is, a lot of these genetic risk factors do sort of push the age of diagnosis earlier. So if you're a carrier in that, we want to be more mindful earlier. The other aspect is that we don't have good data um, outside of sort of the European ancestry, fair skin individual population, in terms of some of these genetic risk factors, to know exactly what they mean, because it just hasn't been studied. Some of the information that we would love to study, which we hope to study in the future, is how some of these genetic risk factors interplay in people that are not as fair skinned and not European ancestry, and also look for genetic risk factors there, because we know sun exposure is probably less relevant for melanoma pathogenesis in people of non-European ancestry. So that's something that hopefully I'll have a better answer for maybe in a few years as well.
Well, we love that you're continuing to study that. It's really great. I'm going to kind of stick with you for a minute, because while all of that heritable genetic information is so powerful, and knowledge, like you said, is power in, kind of controlling your own health journey and future, a lot of people have really no reason to know it. They're unaware of a past diagnosis in their family, and they don't know they're at risk for anything. And so that leaves us with, kind of one tool, and that is sun safety and, better prevention habits. And, knowing that, and knowing also that you see patients every single day, that are at risk or already have melanoma, can you please, share with us what you tell your patients, as far as prevention tips go?
Yeah, I think that's important. Um, the other thing that I would add before I talk about sun safety just for a second is that I think when I said sort of, maybe your lifetime risk would go from 2% to 10%. That also, sort of to your point, Dana, some people won't know that they're genetically at risk because
Right.
it looks like the rest of their family has not had a melanoma. And so I think that's where I hope we can go, is where we can do more genetic testing so people actually know their risk level and can be proactive in terms of detection and prevention. So to segue then into prevention, I think I actually am pretty short with words, not short with my patients, but short with words in terms of sun safety, because I actually think most people come in actually to my clinic pretty knowledgeable about sun exposure, but I'll talk about what I'll give. But also, I think actually more strict on themselves than I would potentially be strict on them. And what I would say, the reason I say that is that we know that tanning bed exposure increases your risk for melanoma. So I would say that that's like a no-go. Like you can easily not go to the tanning bed, not easily, but it is something you don't have to go into rather than going outside. So that, I think, I'm pretty clear, you don't need to go to tanning bed. In terms of going outside, we know that sun exposure, specifically for melanoma, I'm not talking about other types of skin cancer. I'm just talking about specifically for melanoma. I want to be clear about that, not to discourage other things related to other types of skin cancers. But in terms of melanoma, we know that um, the majority of sun exposure that's relevant for melanoma risk is actually earlier on in life in terms of sunburns. probably before the age of 25. And we know that increases your risk 2 to 3-fold for melanoma, which is a lot, but it's not the be all and end all. And the reason I mention that is for two factors. One is a lot of people come into the dermatologist's office with a lot of guilt about the sun exposure that they've experienced, a lot of which was before they had control over whether they were going out in the sun. And so they can blame their parents. That's a different question. But I think it's important for people to recognize that it plays a role, but it's not necessarily the be all and end all. And um, if they happen to get burned, it's not the end of the world at the age of 60. So what I typically tell patients is to find sunscreen that they like, that they're going to keep on reapplying and to reapply it every few hours, and actually use sun protective clothing, which I think is easier to do. And no one burns or tans through clothes, even regular clothes, I would say, unless they have some sort of specific skin condition. And then not and try not to get burned and be smart, not lay out in the sun for 4 hours between 12 and 12 and 4 p.m. Um, you know, try not to get burned. Getting sunburn is not fun. But I think we having sort of a mindful attitude about sort of there's important things that everyone has for their health, and sun and skin is one aspect of their health. And so I want people to do things that they love, whether it be exercising outside and those kinds of things. And so I think being mindful of the fact that you can go outside and do things that you love, but you don't necessarily have to get burned all the time. There's ways to prevent that. And so I think those are the small things that I would say, but also trying to actually alleviate some degree of guilt with regards to that.
I love
Um,
that. That's really a great approach. I'm still thinking about what I would talk to my parents about from the past, but I'll get back
I'm
to you
not
on
trying to create any family drama.
Leah, I sort of want to ask you the same question because as a diagnosed melanoma patient, I'm sure your habits are very, very good, and they might be better, than someone that hasn't had melanoma. But um, tell us a little bit about like how you approach prevention now and what you might tell a friend or a neighbor who, has been lucky enough not to be diagnosed. Is there a difference in what you would suggest that they do?
Yeah, I have a lot to say when it comes to prevention. So I kind of alluded to this in my story in the beginning, but I was not a person that wore sunscreen. The SPF that I was using was an SPF 4 and it was in a tanning oil, which at that point, it's like not even using anything really. Because all I really cared about was being tan. And growing up in the 90s and 2000s, tanning culture was really strong back then and still kind of exists today. And I'm starting to see that come back a lot on social media. We may get into that later on in Q&A, but um, my life just looks so much more different because I think I always tell myself, like, if it weren't for my dad's melanoma coming back stage 4, I don't think I would be as strong as an advocate as I am now and so mindful around prevention. I always tell people prevention is cheaper than treatment. So if we can invest today in, as Dr. Arbesman said, an SPF that you love, sun safe clothing, UPF clothing, let me tell you, that investment will pay off over time. Um, but at the end of the day, there's still a chance that you can get skin cancer or melanoma while wearing sunscreen or while wearing sun-safe clothing. That's a very real thing. But if we can decrease your risk with things that we can do day in and day out, and I like to tell people that sun safety doesn't have to be rocket science. Just like we brush our teeth every day, just like we wash our hands, or we should be wearing sunscreen every day. And something that I learned after melanoma is that you actually should be wearing sunscreen when it's cloudy outside, because I didn't know that around like 80% of UV rays are still going through clouds on a cloudy day. And it made sense to me after learning that fact why I got sunburned really badly on cloudy days in the past. And so I think for me is I would echo really what Dr. Arbesman said is find a sunscreen that works for you you're not going to wear sunscreen if you don't love what you're putting on your skin. So it's important that you find something that you love, and that you will reapply. Some people have trouble with reapplying. I get it, especially on vacation when you're busy, you're swimming, you're doing all these things. That's why sun safe clothing has been honestly like a game changer for me. I always say SPF and UPF is like the dream team, because when you wear both together, you're really making sure that you're protecting your skin. And it's, clothing's not going to wash off or rub off or anything like that. It's just that additional defense again, I guess. And so I think another thing too is something that I struggled with was going from super tan as like a 20-year-old to really pale as I kind of faded throughout kind of like after melanoma. And so I also am really cautious of how I tell people that, it's okay if you want to be tan, but also protect your skin. And the safest tan is the one that comes from a bottle. And I tell people that because for somebody that used tanning beds on and off for about a decade of their life and then got melanoma, the tan is not worth the risk of getting melanoma. And nowadays there's so many different options of self tanner. You can get a professional spray tan, and that is something that I have done after melanoma. And I don't want to say like it makes me feel more normal, but it kind of does in a way, because it feels like I still am able to look like I did kind of before melanoma, if that makes sense. So I hope all that makes sense as far as kind of what I would tell other people.
It does. Thank you for sharing all of that. Before I move on, I do see we have a question, and it kind of pertains to the chat that we were just having. And the question is, what is the difference between SPF 30 and 50? A lot of people are confused by those numbers. So does one of you want to take that?
Yeah, I can talk about that. I think so it is essentially a multiplicative factor. And I say this essentially because actually some of the things we're learning is that the numbers are not as exact as we would hope on those SPFs. That this is not to disparage any company or anything like that. It's just it's not as exacting. And on some level, it's supposed to be sort of, how much time you can go out in the sun without burning, and then that gets multiplied on some level. It's not exact because it doesn't actually work in that regard. And also most people don't put on enough sunscreen for it to necessarily work in that regard. Um, I'm not a particularly strict person about saying you need to have the highest SPF that you can get, because it doesn't see, there are studies that will show a middling amount difference, but it may not be necessarily a practical difference. And also, the critical thing for most people is that reapplication, because if you're reapplying, say, for example, rough numbers, it takes you 10 minutes to burn, and you multiply that by 30, that's 300 minutes versus 600 minutes. You theoretically should be reapplying your sunscreen before 300 minutes, because it most likely was sweat off or washed off if you're out in the water. So, from a practical perspective, as long as the numbers are real, which they're not necessarily exactly real, but I think the critical thing is that reapplication. I'm not strict that you have to go the highest SPF. Some people will give you a different answer on that, but that's doesn't necessarily my mindset.
Great. Well, thank you for that. Um, Leah, your mom was incredibly astute when she noticed the mole on your chest. She clearly, had every reason to, be cautious and to be alert to things like that, but not everybody is. So let's talk about what early detection looks like for somebody that, hasn't experienced this in their family. What should people be looking out for? What should they do themselves? What are sort of the best practices in the early detection realm? Dr. Arbesman, do you want to go first?
Sure. Yeah, so I think the first step is having a little bit of a sense of your own skin, which I think is difficult. Difficult knowing some moles, knowing your moles, but sort of getting a sense of what your moles are, or what your spots are, I think is easier to say. Although that is difficult sometimes on our back or other areas. And if you're able to co-opt someone, a loved one to help you sort of look at that, and you can, pair and look at their back. I think that's important because it's a lot of this is about baseline. What does your skin look like? And then we layer on top of that. I think actually the ABCDs are quite good. I think they are helpful, but I generally focus for most people on E, and I'll go through what they all are. Um, and we're talking about, I guess I'll take a step back and sort of say we're looking at sort of essentially any spot on your skin. A lot of people make a distinction between a mole and a freckle and then a bump and this kinds of thing. I would actually sort of say let's put that to the side because the majority of melanomas will start out flat, and most people think moles should be raised, but melanomas can start out flat. So that's a critical thing to know. And so then we talk about A, B, C, D, E. So say we're looking at a brown spot on our body. A is for asymmetry, is one half not matching the other. B is for border instead of a nice round border, which a lot of our moles have. They can be more jagged. C is for color instead of one color. It can be multiple colors or very dark compared to the rest of your moles. D is for diameter, which is a little bit of a weaker sign. We talk about a diameter of 6 millimeters, so larger than that, we start to get concerned, which is the majority of melanomas will be larger than 6 millimeters. We do find melanomas that are smaller than 6 millimeters. And then we have a lot of benign spots that can be larger than 6 millimeters. And then the last is E for evolving, and I'll talk about that in just one second. But the critical thing about all of these is that you don't have to have all of them to be concerned about a spot. Potentially one can lead you to be concerned. The key thing that I say about E for evolving is two things. One is, are you noticing a change over time, in a month or every 2 months that the mole is looking different and bigger and maybe looking to have one of these A, B, C, D signs? Or we call it the ugly duckling sign. Does that spot look different than the rest of the spots on your body? But and I think that is sort of intuitive for us to sort of get a sense of, is something looking different? We can see that, and we can also get a sense, does this look different than our moles? The challenge is for some people, they may have an above average number of moles. Their moles are not going to be perfect. That is not an insignificant percentage of my patient population. And so in that realm, that's why I sometimes don't focus as much on ABCDs, because for some people, half of their moles may fall into that criteria, and we're not going to biopsy everything, and they are not melanoma. And so I think having that intuitive sense, and we're going to have technology that's going to help us, over the years, where it's going to actually be able to detect melanoma earlier and sort of detect those changes. I think that's critical for us to look at. But it starts with sort of a knowledge of our skin. For some people, that's intuitive. There may be more visual-based people. For people, it's not as intuitive, and sometimes that does require partner or dermatologist
Mhm.
assistance in that regard. And even if we do have something that's changing or new or different, that doesn't always mean that it's going to be a melanoma. So just finding something that's of concern doesn't mean that when you come in, number one, it may not get biopsied, and number two, even if it does get biopsied, it may not be a melanoma or a skin cancer. The other
Thank
thing that I
you.
would mention, one
No
other
worries,
thing,
please.
thank you, is that most melanomas are going to be brown or darker brown or even black, but there are some melanomas that could be red or pink or purple. So just because it's not necessarily dark doesn't necessarily mean that it's not a melanoma, as well.
Oh, yeah, all good things to watch for. Thank you for all of
Mhm.
that information. Leah, if I may go a little personal here, I'm sure you do your own self-exams and then you have routine appointments with your dermatologist sitting right here with us. Can you walk us through a little bit about your routines?
Yeah. So in between every 6 months that I just recently got graduated to, I think as of last year, which was on me, I will say. I think Dr. Arbesman wanted me to graduate 2 years after melanoma. He's like, "Are you ready?" And I said, "No." And he listened, which I so appreciate that. So I felt confident in doing every 6 months, I believe, last year. But because of that, every month I do what's called like self monthly skin exams on my own at home. So obviously I get to know my skin, as Dr. Arbesman said, you know your skin best because you're the one living in it every day. You're the one looking at it. And so I try to, at my best ability, track any moles that I think may be looking a little funky or off or anything like that. And then always bring Dr. Arbesman, to like bring attention to that, because I think that that's important. I also will take pictures on my iPhone using moles, because we're human, we can forget things. And when you're looking at the same thing almost every day or every week, it may not look like it's changing to you, but your camera is a really good tool to use. And then again, showing those pictures to your dermatologist. There's obviously parts of my body that I can't see. So my husband is a really good person that can, look at my back or anything that I can't see in my hair or anything like that. So having like a partner or a family member that's able to check those areas for you. Also, people that do your hair. I've heard incredible stories that people like in salons or barbershops that have spotted things on people's scalp, and encourage them to go get it checked out. I think that's incredible, just having people in your corner to look at areas that you can't see. And yeah, I think something that, I think it's important for people that have had melanoma that we kind of live through afterwards is anytime you see a dermatologist, look at a mole a little bit more careful with that dermatoscope, or go back to the mole, check it again. It does create some anxiety, right? Because the feelings can come back of, skin cancer and melanoma. That's a really real thing. But I think Dr. Arbesman brings up a really great point, and it's something that I've had to learn over time. And when I say time, I'm talking years. Not every biopsy is going to lead to melanoma. And it's important that we reframe a biopsy as in a sense of, if this is something, we're catching it early and we're diagnosing it and we're being proactive. And I think when you reframe your mindset like that, you start to see a biopsy from negative to positive. And so, like I said, that's taken time to get there. But I think also it comes down to having a really good relationship with your dermatologist and making sure that you're feeling seen, literally, and heard. I think that that's really, really important.
Wonderful. Thank you so much for that. Another question came in that is relevant to what we're talking about. One of our guests said, what if a patient is absolutely convinced that they have a mole that is melanoma, and you check it and you believe that it's not, Dr. Arbesman? What do you do? Do you biopsy it? Do you wait and see? I'm sure it is a case-by-case situation, but can you address that a little bit, please?
Yeah, I think that's an important question. I'll add two things first, and then I'll answer the question to what Leah said, which I thought was very good. One thing about looking at your skin too frequently at home is that you may not detect changes. So we actually, sometimes that's sort of why I say maybe once a month, once every other month, so that you actually may miss things, to just build on what Leah said. The other thing is that right now our ability to detect melanoma is good, but not perfect. And so we don't want it to be a sort of a one-to-one relationship of biopsy to melanoma. And so we will actually biopsy, a fair number of things to make sure that we're not missing any melanoma. To the question at hand, sort of related to that. So I think it depends on the data that we have at hand. If I think that the spot is not even in the mole category, and something benign that is completely different from the mole sort of general category, or melanocyte driven, so those pigment producing cells that would lead to moles or melanoma, then I talk to the patient and sort of say, I think it actually is Y, not X, and can we think about watching it, because I actually think it's in a different category. That's one situation. Second situation is, say it's a mole in the mole category, but I think it looks benign. Then I sort of see what data we have to help us. I take a lot of photographs, whether it be total body photography or individual mole photography, and sort of see, do we have data that helps us say this mole has been completely stable for 5 years, or does it look a little bit different? Because sometimes, my original sense will be influenced by whether there's data that says something has changed. So if it has changed, then I may say, okay, I think it is reasonable to biopsy the spot. If it's been normal or stable for 5 years and look the exact same, then we'll have a conversation with saying, I think it does look the same as it did. It's highly unusual for melanoma to look the same for 5 years. Maybe we can watch it and sort of monitor it, get a lot of good quality photos. If we have no data to help us and it is in that mole category, then it's a conversation. I don't want people to leave with high levels of anxiety. We're not perfect as dermatologists, but I also don't want us to necessarily do biopsies that are I wouldn't say unnecessary, but unlikely to yield a melanoma diagnosis. And so that's sort of the conversation I would say. If someone is concerned and they say, I think I would still rather them that you do the biopsy, then I think it's reasonable to do a biopsy. We're not perfect, but I would sort of give my insight in that situation, knowing that we're not perfect, and a lot of people will have stories that they come to me and said, their dermatologist was unconcerned about the spot that ended up being their melanoma, and that can be very difficult going forward, that people don't feel heard in that regard. And so I think that's also critical, that it's not just about what is the right answer, it's also, well, this is part of the right answer, but that not what is it melanoma or not melanoma, but also about what is right for that individual. So I
Yeah.
think to Dana, to your point, it is sort of case by case, and that was a long-winded answer to sort of say case by case, but it's sort of how I think about it and process it.
Yeah, no,
Uh,
no, all of that logic does really help. And I guess just as a fellow patient advocate with Leah, I would also say, like, and I'm sure you agree too, Dr. Arbesman, patients do know their bodies best, and to listen to your body, listen to that little inner voice
yeah,
and pursue things that bother you. It might not be anything, but it never hurts to ask. So
sure.
I think that's like the lesson that we all should learn. I can't believe we're already, honing in on the end of the hour. I do want to get to a couple of questions that came in from the registration, if that's okay. The first one is a really interesting one. The question is, my melanoma was subcutaneous rather than originating from a visible mole, and I had essentially no symptoms. How common is it for melanoma to present that way, and why can it be so hard to detect?
Yeah, so I'll take that one. I think that's a good question. I'm not sure. I hear sort of two questions when someone says subcutaneous, so I'm going to answer both of them. One is that the melanoma didn't have pigment and it didn't look like a classic mole, something we sometimes call an amelanotic melanoma without pigment. So that definitely does occur. I'm not sure if that was the question, and that's why I sort of said at the beginning when I was talking about it doesn't have to look like a mole. So that would be sort of to answer that. But they may be talking what we call melanoma of unknown primary, where we find sort of a lump internally or in a lymph node sort of in the armpit and the neck and in the groin, where there's sort of a lump that occurs. It starts to grow, it gets sampled, and they find out that it's melanoma. And there's no visible mole that's led to that. And that's probably, I think, what the question is, but I'm not certain. Um, Thank you. Yes, so thank you for validating. So in terms of that, um, it's probably depending on the study, it's somewhere between 2 and 5% of melanoma. Some estimates push it down a little bit lower, maybe 2 to 3%, but it's definitely a not insignificant percentage of all melanomas. If you think about sort of some of the rarer subtypes and stuff like that, it actually does comprise non-insignificant percentage. I'll just spew for 1 second. There's different theories about how that occurs. Many people believe that it starts from a mole that then your immune system decided to take away that was a melanoma, and then was still there were some cells that were able to spread, and I think that definitely occurs for some people. But a lot of people, they will not report anything that looked weird that disappeared, and when you look, you will not find anything. So I would say, um, then there are some people we know that actually we can make moles inside of our lymph nodes, and so there are those melanocyte, those pigment producing cells. So it's possible that those are some of the cells that acquire additional changes and
Yeah.
become melanoma. So that's what I would sort of say is from the scientific side, but it's not an insignificant percentage, but it's not the majority of people.
Thank you. So we kind of addressed the second question a little while ago. How should young women today balance the sought after tanning culture with actual sun safety? So Leah, you mentioned the best tan is in a bottle. Do you want to elaborate any more on that?
Yeah, I mean, I think it's natural for both men and women, maybe in the summertime or warmer months, or when we want to go on a trip somewhere beachy. A lot of people would want to have some type of glow to their skin, tan, whatever. I think that's normal, and I think it's normal for us because it's been a societal kind of norm for so many years. Um, because I'm a melanoma survivor, I have geeked out in learning about like tanning culture and kind of where that all came from years ago. And I won't get into that today, but I encourage everybody to kind of look at that because that those societal standards came from somewhere. And especially for somebody like I mentioned before, growing up in the 90s and 2000s, when we saw women or men on magazine covers or in the media or movies or TVs, they were not pale. They had a tan, they had a glow. And so naturally, that's something that, we want to have or look like or what have you. So I think for somebody that really chased that kind of tan for so many years and did everything to achieve it, with also the lack of knowledge that melanoma or skin cancer can happen to somebody at a young age, I guess I just wasn't prepared for that happening to me. And so I always tell people, kind of looking back, is that I get it. I get that you may want to be tan. You may want to explore a tanning bed. You may want to lay out in the sun. And I come from a place of I understand it. I get it. I've been there. But also, I try to share my story in a way of, when you do those things, it doesn't mean you're going to get melanoma or skin cancer. It just means you're increasing your risk of potentially getting it. And when we look at risk for anything in life, I mean, we wear seatbelts in cars, right? It's kind of the same aspect here. We try to do as much as we can to prevent harm from happening to us. And I think we have to look at the same thing when it comes to, tanning or, anything like that. So as I mentioned before, I think if somebody wants to tan, getting it from a bottle, like I said, there's so many great self tanners that you can get at Target, Ulta, Sephora, drugstores, anywhere nowadays. And they're not the ones like they sold in the early 2000s that make you look like an orange. They actually make you look pretty good. And that's great. Or you can get a professional self tanner or spray tan. That's always good too. But I always tell people that, just also try to embrace who you are. And that is something that I've learned after melanoma, that, for somebody who chased a tan for so many years and then got melanoma, I always look back, what if I just accepted my own skin tone and just embraced that? I don't know if I would have gone through what I've gone through. Maybe I still would have, but it's just not worth it. And so if you want to have a tan, there are safer options to do it. And if not, just embrace who you are because you're beautiful just as you are. So.
Love that. Love that. And I think your future self will thank you too, just as far as like wrinkles and skin damage go, right? Like that's something
Yeah.
that all of us, can probably agree with. Okay, a couple of other quick questions. Is there any safe time to be in the sun? And I know you have kind of a nuanced answer to this, Dr. Arbesman. The question said, is 5 to 8 a.m. okay, or 6 to 8 p.m.? I know you believe in being careful, but not limiting your life.
Yeah, I think that's an important question. I think it goes along with sort of what I said. Obviously, there are some areas of the world that are the sun is more intense at different hours, and we have to be mindful. If you go out at a certain hour and you find that you are burning, then you have to be more careful. I do think from 5 to 8 in the morning, we know that the sun's rays are not as intense, and I think for the vast majority of people, that's probably fine. Later hours as well. I think that comes from sort of finding that balance. And also some people are still, if they've had melanoma, they may be uncomfortable in that situation going outside. I think it takes gradual steps. I think the vast majority of at 5 a.m. there's very little sun for most people. I mean, obviously during the winter, that's not probably what the question was about. But yeah, I think there are times where it's okay. And if you're wearing, clothing and having, minimal exposure, I think that's completely fine.
Awesome. Thank you. All right. So back to the clinic checks one more time. Somebody who submitted a question said, do you have any tips for easing anxiety between the 3-month checks? This person is a stage 1A and has had their first excision, and I can imagine that it does lead to anxiety with every visit.
You want me to take that one, Dr. Arbesman?
Yeah, you could if you want to start, and then I can add a little bit
Yeah,
yeah.
we can do the patient and provider
Sure.
aspect. I totally can empathize with this individual, a fellow stage 1A, individual, and a lot of anxiety, which Dr. Arbesman knows far too much about. But, I think it's just normal because at any stage of cancer, cancer is cancer, and it really can impact you mentally, emotionally, as well as physically. And this is actually something that Dr. Arbesman and I have talked about in the past that I don't know how old this individual is that submitted this question, but, from my experience, getting diagnosed so young, and then after that, having a lot of biopsies all before the age of 30 was really weighing on me as a young woman. And I was truly scared of, is this how my life's going to be? At this point, I'm going to look like Frankenstein, with all these scars on me and all that kind of stuff. And so I think what you have to remind yourself is that kind of what I mentioned before is that, yes, biopsies can sometimes be really painful. And, leaving every skim check with a biopsy can feel a little bit defeating in the beginning after a diagnosis. But your dermatologist and your team is looking out for you. They are doing this because they truly want to be sure that you don't go through melanoma again. And they are going to watch you a little bit closer than somebody that may have not have, skin cancer, melanoma. So I think it's a lot of reframing your mindset and understanding that, your dermatologist is doing the best for you. A biopsy doesn't always mean bad or doesn't mean melanoma. And just really kind of not always seeing it from a negative lens, I guess, if that makes sense. Dr. Arbesman, I don't know if you want to touch on that, but.
Yeah, no, I think these are all good points. I would add a couple of points. One is not I know the anxiety after melanoma diagnosis is typical. It's not inappropriate. It's not the wrong thing. And I think anxiety in that situation is a productive thing to remind you to be looking at your skin and to be careful and to go to your skin check. So I think we don't always need to frame anxiety as a negative emotion. I think it can be a positive emotion in this setting, and it is very typical. If someone came back and had no concerns about themselves, I would be a little bit sort of concerned that maybe they're not necessarily taking it so seriously. So that would be point one. Point two that I would add is that, and it obviously depends to Leah's point on the age at diagnosis of melanoma, but the majority of people that have had one melanoma do not get a second melanoma. And so that's pretty clear in the data. And so most people that are coming for skin checks are not necessarily going to get another melanoma. They may get more biopsies, and you want to find a dermatologist that is reasonably balanced in terms of how many biopsies they're doing to detect melanoma. I think that's critical. But I think that's also something to keep in mind, that it's not a guarantee that you're necessarily going to get another melanoma. And then the last thing that I would say is that the good thing is 3 months is actually a pretty short period of time. A lot of people will get 3 month checks. That's actually a pretty short period of time, such that even if you notice something of concern, and the majority of the time you just read the dermatologist, you're about to go to the dermatologist. But the flip side is, I think finding a dermatologist that you can trust and develop a relationship with, that you can say, is this worth coming in for a check or not? That sometimes is also helpful, because that can at least be a quick determiner. I don't think that's a word, but of whether or not you should come in, and that can help sort of settle oneself in those early moments. And then the last point is, if the anxiety is affecting your life and sort of not a helpful anxiety, but it's sort of, then it is something that I think is important to bring up and to sort of seek out, counseling or someone to talk to, because it shouldn't completely upend your entire life. And that's something that we should always be mindful as well, is when anxiety turns from a positive force into something that is unhelpful, and then that's okay. That's part of life, but then seeking out the care for that is important as well.
Awesome. Thank you. Renee, any other questions that we need to be aware of now that we're at the top of the hour?
One more, and we will end it at that. So somebody wrote in who has a history of both melanoma and squamous cell carcinoma. Dr. Arbesman, you had mentioned very briefly at the beginning some of the other skin cancers. They want to know, is this just a coincidence or is there a correlation?
Yeah, I'll be quick. So yes, people that have had one type of skin cancer do have an increased risk to develop other types of skin cancer. So that is something that as a dermatologist we're looking out for. Patients should look out for. It's not a guarantee, but a non-insignificant percentage of my patients will have more than one type of skin cancer. And so, yeah, I guess that would be the short answer.
Awesome. Thank you. Well, since we talked about other types of cancer, I do want to recognize that we did not mention checking your nails or the palms of your hands or your feet. It's a different type of cancer called acral melanoma, but those are always places to keep an eye out for too. Make sure your dermatologist checks those areas, or if you notice any changes in your vision or spots in your eyes, that's another place to, be mindful of. But given that we are now a minute or two over, I can't think of two people that, would be better than the two of you, Dr. Arbesman and Leah. Thank you so much for sharing your expertise and your experience. Both go a long way in helping to educate others. And I hope that everyone who joined this webinar learned something and will share it with others to help keep everybody in their lives safe. We will record or have recorded this webinar, so it will appear on curemelanoma.org. Sorry. Shortly, you can check there to rewatch or share it with others. Thank you so much for joining. And remember that even though May is coming to an end, melanoma awareness should be part of everybody's lives, and sun safety should always be there too. So thank you so much.
Thank you.
Thank you.
Thanks, everyone. Have a good rest of your day.